Welcome back to Prescribing Hope, Azithromycin Unmasked. I'm Rittika, your host with a master's in neuroscience, passionate about decoding the science behind azithromycin's unexpected role in COVID-19 pandemic. In today's lecture, we are going to look at the immunomodulatory effects of azithromycin in COVID-19. We are diving into how this antibiotic's immune taming ability shaped its early usage against a viral storm. Rejoining me is Saakshi, who appreciates the immune system like a composer reading a score. She'll show us how azithromycin tried to soften COVID 19's immune response or the immune crescendo with its quite immunological notes. Welcome back once again.
Thanks, Rittika. I am thrilled to explore azithromycin's immunomodulatory magic. It's like uncovering a hidden chapter in this molecule story.
So let's open that chapter. Azithromycin's immunomodulatory effects were a key reason for its COVID 19 spotlight. Can you detail how it modulates the immune system, including the specific cytokines and the pathways which were involved, and how these effects differ from its antibacterial action?
Absolutely. Azithromycin's immunomodulatory effects are distinct from its antibacterial role, where it inhibits bacterial protein synthesis by targeting the 50S ribosomal subunit. As an immune modulator, it dampens excessive inflammation by targeting host immune cells, particularly macrophages, neutrophils, and airway epithelial cells. It reduces pro-inflammatory cytokines, interleukin 6, interleukin 8, tumor necrosis factor alpha or TNF alpha, and IL-1 beta, which are key drivers of inflammation in infections and chronic diseases. Mechanistically, azithromycin inhibits transcription factors like NF-kappa B and AP1, which activate cytokine gene expression. By stabilizing I-kappa B and NF-kappa B inhibitor, it prevents NF-kappa B from entering the nucleus, effectively muting inflammatory signals. It also suppresses inflammasome activation, reducing IL-1 beta release, and shifts macrophages from pro-inflammatory M1 to anti-inflammatory M2 phenotypes, promising tissue repair. These effects occur at sub-antimicrobial doses, example 250 mg daily, unlike the higher doses, that's 500 mg, used for bacterial infection. In vitro studies like those in Journal of Immunology 2004 showed azithromycin reduced IL-8 production in bronchial epithelial cells by 50 to 70%, highlighting its anti-inflammatory potency. This immune calming action, independent of ribosomal binding, made it a candidate for diseases driven by inflammation, setting the stage for its COVID-19 exploration.
Saakshi, you have unveiled azithromycin as a molecular diplomat, silencing the immune system's war cries by dimming cytokines and soothing fury paths. Its shift from bacterial assassin to immune pacemaker is a warrior trading a sword for a laurel wreath. This immune taming ability was particularly relevant for COVID 19's hyperinflammation. Can you explain why azithromycin's immunomodulatory effects were as seen as a potential game changer for severe COVID 19 cases, and what specific clinical observation fueled this hope?
In severe COVID-19, a hyperinflammatory state known as cytokine storm often drives acute respiratory distress syndrome or ARDS and multi-organ failure, particularly in patients requiring ICU care. Elevated IL-6, IL-1 beta, and TNF alpha levels reported in The Lancet in March 2020 were linked to mortality rates of 20 to 30% in hospitalized patients. Azithromycin's ability to suppress these cytokines, proven in chronic lung diseases such as cystic fibrosis, made it a promising candidate to mitigate this storm. Its high lung tissue concentrations, which is 1 to 8 microgram, as we discussed in episode 4, positioned it to act directly at the site of SARS-CoV-2 induced inflammation, potentially reducing lung damage. Early clinical observation amplified this hope. A 2020 French study by Gautret et al., published in International Journal of Antimicrobial Agents, treated 80 COVID-19 patients with azithromycin and hydroxychloroquine, reporting a 93% viral clearance rate by day 8 and reduced hospital stays as well. Another study from New York in Clinical Infectious Diseases in June 2020 noted that azithromycin treated patients had lower IL-6 level and fewer ICU admissions, which was 15% versus 25% in a cohort of 200. These small, non-randomized studies, combined with azithromycin's safety profile and outpatient-friendly dosing, 500 mg on day 1 and 250 mg from days 2 to 5, suggested it could stabilize patients early, preventing progression to severe disease. The hypothesis was that azithromycin could bridge immune modulation with bacterial co-infection control, a dual role that seemed tailor-made for COVID-19's complexity.
Saakshi have cast azithromycin as a hopeful firefighter, rushing to douse COVID 19 cytokine blaze with its lung homing balm. Early studies, like sparks of promise, lit up hopes, but it could calm the storm and save lives. Yet those hopes face scrutiny in clinical trials. Can you dive into the major trials that tested azithromycin's immunomodulatory effects in COVID 19 and why the results didn't match the initial optimism?
The optimism around azithromycin's immunomodulatory effects was tested in large-scale randomized controlled trials, or RCTs, in 2020, 2021, and the results were sobering. The recovery trial, published in The Lancet in February 2021, randomized 2,582 hospitalized COVID-19 patients to azithromycin, 500 milligram daily for 10 days, versus 5,184 to usual care, finding no reduction in 28-day mortality, 22% versus 21%, where the p-value was equal to 0.73. Hospital stays, where the median was 10 days, or ventilation use. The Solidarity trial, spanning 30 countries, tested azithromycin in 1,411 patients, reporting no benefit in mortality or even clinical progression. The principal trial, focusing on early outpatient cases, found azithromycin 500 mg daily for 3 days did not shorten recovery time. It was 7 versus 8 days, and the p-value was equal to 0.53 in 540 patients. Several factors explain these outcomes, like timing. Timing was definitely a major issue here. Many trials enroll patients in late-stage disease, 7 to 14 days post-symptoms, when irreversible lung damage had already set in, limiting azithromycin's ability to modulate inflammation. Its effect on IL-6 and IL-8, while significant in vitro, 50% reduction, was modest in vivo, insufficient to counter the massive cytokine surge in severe COVID-19, unlike corticosteroids like dexamethasone, which reduce mortality by 30% in recovery. Patient heterogeneity diluted results. Not all had cytokine storms, reducing the drug's impact. Additionally, azithromycin's cardiac risk, like QT prolongation, 0.1 to 1% incidence, and rising resistance, 20 to 40% in streptococcus pneumonia, raised concerns. These null findings, consistent across settings, showed that azithromycin's immunomodulatory effects were too subtle for COVID-19 scale, redirecting focus to more potent anti-inflammatories.
Saakshi, you framed azithromycin's trial journey as a valiant bard singing a soothing lullaby to COVID 19's chaos, only to be drowned out by a diseased roar. Its modest effects, like a gentle breeze, couldn't shift the storm's tide, teaching us precision matters. Bees trial outcomes highlight the rigor needed in science. What broader lesson did azithromycin's COVID 19 experience teach us about the role of clinical trials in validating immunomodulatory treatments? And how should we approach such therapy in future pandemic?
Azithromycin's COVID-19 saga underscores the indispensable role of clinical trials in separating hope from reality. Early excitement, fueled by small studies like Gottred's, relied on weak designs, lacking randomization, blinding, or adequate controls, which overstated benefits. Large RCTs like Recovery and Solidarity, with thousands of patients and robust methodology, provided clarity, showing no immunomodulatory impact was significant enough to alter COVID-19 outcomes. This highlights that in vitro promise and observational data, while valuable for hypothesis generation, must be validated through rigorous trials to ensure efficacy as well as safety. For future pandemics, we need adaptive trial platforms like Recoveries, which tested multiple drugs rapidly while maintaining scientific rigor, enrolling 10,000 plus patients in months. Early phase trials should focus on pharmacokinetics and biomarkers, example IL-6 levels, in order to identify optimal timing and patient subgroups, as azithromycin's late-stage failure showed timing is very critical. Global collaboration, as in Solidarity, accelerates data collection, while stewardship is vital to prevent resistance spikes, like the 10% rise in macrolide resistance during COVID-19, Antimicrobial Resistance and Infection Control 2022. The lesson is to balance urgency with evidence, use preliminary data to guide, but let RCTs decide, ensuring treatments like immunomodulators are deployed with precision and not desperation.
Saakshi, you've depicted azithromycin's trial legacy as a lighthouse. It nulls results illuminating the rocky shores of rushed science. Like a compass, rigorous trials guide us to the truth, ensuring future therapies sail true in crisis. Thank you, Saakshi, for this illuminating dive into azithromycin's immunomodulatory trials. I'm Rittika, and this is Prescribing Hope, Azithromycin Unmasked. Stay curious.